the first of probably a half dozen sessions on COVID-19. We're beginning with general demographic insights into COVID-19. And this session has really been organized by Jen Dowd, who has organized the program. Sara Curran and her group at Washington have organized the technical aspects, which are always harder than you expect in these instances. We're very much looking forward to hearing from 4 different panelists. Jen Dowd from the University of Oxford, as I mentioned, then Steve Goodreau from the University of Washington, Marcia Castro from Harvard, and Andrew Noymer from the University of California at Irvine. So each of our participants will speak for somewhere from 12 to 15 minutes. And then after that, people will have the opportunity to ask questions. People will put their questions into the chat box. No one but the presenters is able to speak or be seen. And we have these privacy mode on in order to prevent disruption of the meeting. So in the chat box at any time, you can address your questions to either to one of the co-hosts, Sara Curran, or to me, or to one of the panelists. But Sara Curran and I are going to, after the presentations, alternate in choosing questions and directing them to one of the participants to answer. That'll be the format we use. Now, the meeting is also being live streamed, and so questions from the YouTube site will also be coming in via the PAA office. So there are many ways for people to come in and ask questions. And we hope that we're able to address some of the important ones. If we're not able to get to your question, just contact one of the speakers after the meeting. So we've been a little late getting started. I think we want to get going here. So we'll begin the session with Jen Dowd. Jen, would you like to share your screen?
Yes.
And unmute yourself.
Yeah, there we go. All right, can you see that?
Yes.
All right, great. Well, thanks to Eileen and Sara for this opportunity to continue PAA and have a way to connect and recapture some of that magic that we're missing from the in-person meeting. Really happy to be here. I'm connecting virtually with you guys. So I'm going to talk a little bit about work I've done personally along with colleagues in my center, but I also wanted to hopefully set the stage for a broader discussion of how demography can contribute to understanding COVID-19 in the short and long term. So I'm going to start with the classics of age and sex, but we know this pandemic will be shaped by and in turn shape many demographic dynamics. So I want to really urge the PAA community to bring their expertise to bear on this important issue and continue to do impactful COVID work. I think in addition to epidemiology, which is appropriately kind of in the limelight right now, demography really is needed now more than ever. So like many of you, in February and early March, I found myself following the COVID news with personal curiosity that quite quickly became professional interest once the scope of the crisis became clear. And for me and my colleagues, this happened while the virus was raging in Italy, where 2 of our postdocs were on lockdown, including in the Lombardy region, and sending frequent updates. And of course, Italy was the first place outside of Wuhan where the total number of deaths really became alarmingly high. And so starting to follow this daily mortality data, which you can see an example of here from Italy, And this is from May, but the pattern was very similar in the March data. I think as demographers, the most noticeable thing was the stark age pattern of mortality. And I know most of you are familiar with case fatality rates, but just in case, the denominator here is confirmed cases of COVID, which obviously depends a lot on the extent of testing in different contexts across countries. So one important thing that demographers were super quick to jump in on was to pay attention to the denominator, especially in these very early days of trying to get a handle on how lethal is COVID exactly compared to other threats, like a bad flu season, for instance. But we really kind of had to make do with this emerging imperfect data and try to make sense of it. And so these, not only death rates, but total death numbers were really kind of shockingly high coming out of Italy, especially for a wealthy country with, a good healthcare system. So even if you don't take these case fatality rates at face value, the distribution of deaths by age was very clear, with over 95% of deaths occurring at ages 60 and up. So in thinking about why mortality was so high in Italy, it seemed like the most obvious but important demographic point that Italy is the second oldest country in the world, with 23% of its population above age 65. So for any kind of given infection prevalence that's uniform across age, population age structure will have a big impact on the expected COVID hospitalizations and mortality, both across and within countries. And in fact, the day that our preprint came out, I learned that every demographer in the world was thinking the exact same thing, thanks to this clever tweet by Monica Alexander, which I really appreciated. So the point about age structure we wanted to make was really just stating the most demography thing ever, which I took as a compliment. And indeed, other parts of Twitter were already kind of pointing out what was on demographers' minds as this COVID mortality data started to come out. And in our paper, we illustrated this most, demography of demography points with what else? Population pyramids. And we really just wanted to make a couple of stylized comparisons. We first looked at Italy and South Korea, two countries that were being impacted at the time. And, with Italy having an older age structure, the basic idea was that for a given rate of infection, which we assumed, to be about a 10% population infection prevalence, and using the age and sex specific case fatality rates from Italy at the time, older populations will face a much higher expected number of deaths, simply because of this concentration of deaths at older ages. And we also looked at this in two countries that had not at that time yet been impacted, Brazil and Nigeria, with similar total population sizes, but very different age structures. And you can just see how that translates into a much higher expected number of deaths. And I think Marcia may comment more on how things have actually played out in Brazil, but it does still seem true that Africa seems to be doing better than expected, which could be for lots of other reasons. And, they still face extra challenges of different comorbidities and, infections like HIV and TB, but it could be the case that a younger age structure is protective of Africa, at least in some respects, for COVID. We also looked at 3 examples of sort of older populations, a middle age structure like the US, and then a very young population, and how this dynamic would play out for overall mortality at different levels of infection. So, as the infection becomes more prevalent across the entire population, these differences in age structure kind of get exaggerated as far as deaths adding up. And thanks to my colleague, David Brazel, for the nifty animation. But overall, our illustrations suggested that countries and local areas with older populations would need to, potentially take more aggressive protective measures because of this high degree of concentration of vulnerability. And the other demographic factor that we kind of discussed in our paper was that high levels of intergenerational co-residence and contact may also have put Italy more at risk. And this was a hypothesis proposed by my Italian colleagues living in the region, who reported a lot of young people working in Milan and commuting out to the villages and still living and dining with older relatives on a daily basis. So I think it's important to point out that it's not, a singular factor like an older population age structure, but potentially the interaction of age structure with other demographic factors like household and family structure that may have really helped to accelerate the transmission from initial entry points into more vulnerable populations. And a piece by Nicoletta Balbo and Francesco Bellari and colleagues kind of showed, using some shared data, these different levels of intergenerational contact across countries, showing much higher rates in the Southern European countries, in Italy and Spain, that are consistent with this idea. So I think with also what we're learning more about the importance of close contact and household transmission for COVID, these family structures and living arrangements are something really important for demographers to pay attention to. And during the early days of the UK epidemic, we extended this work in our group to look at population age structure at a more local level and how this intersected with also hospital capacity at the local level, to try to identify kind of pressure points that might see a large number of critical cases based on the age structure and a shortage of hospital beds. So it's just an example of how understanding population level risk might be able to help inform planning and prevention with regards to COVID. And Shannon Monad and her center at Syracuse highlighted the big differences in population aging across urban and rural America. And I think this will be an interesting thing to watch for short-term versus long-term dynamics, because we know that sort of the dense urban areas with international travel, like New York City, were very vulnerable for early outbreaks, but it could be that as the epidemic diffuses across the country, rural areas may face a higher burden of mortality. And I think it's also important to point out that this basic age adjustment is also necessary in other contexts within countries, for example, looking at race, ethnic differences in mortality. So just looking at raw kind of mortality data, the percentage of Latino deaths, that are amongst Latinos in New York City compared to their prevalence in the population looked about equal, but this kind of obscures the fact that Latinos are much younger, have a much younger age distribution, so they should actually have many fewer deaths based on the age profile of COVID. So it's important to adjust for age in many contexts, and that kind of just brings me to that take-home message that, given the reams of raw mortality data coming out, demographers still should really not be shy in pointing out the most demography thing ever, that age structure is important. And even despite the importance of this for COVID, as we've seen, it's surprising how many countries and local areas are not routinely releasing their COVID data with key demographic information such as age and sex. So I know everyone out there listening who has any connections with national statistics agencies, please lobby for quick public release of this type of data. And next, I don't have time to do this part justice, but I did want to touch on another important demographic aspect of COVID, is that we're consistently seeing that men of all ages have a significantly higher risk of dying from COVID compared to women. And I wanted to point you towards this site, Global Health 50/50, which is collating case and death data by sex, and is really useful from that respect. But of course, there are fewer men at older ages to die, and we're still seeing them die in a higher proportion of deaths. So kind of trying to look at the actual risk of death. There's some data from David Spiegelhalter here with England and Wales mortality data. And I thought it was really interesting, first of all, that he shows that COVID population death rates are, roughly proportional to normal death rates for the over age 45, but well below normal numbers for younger ages. And men have roughly double the risk of dying compared to women of the same age. So, and just to note, these rates are in addition to normal deaths and over a period of just a few weeks. So that makes them kind of even more frightening. And I think the reasons behind these sex differences in mortality are still completely open and under investigation. We know there's differences in immune function, comorbidities, health behaviors, but it's definitely an open question for investigation by demographers for sure. And so one of the challenges I mentioned earlier that we're facing is really trying to understand the true mortality, how risky is COVID for the general population and for people who are infected. And it's very difficult because we know that both our, denominators of who's actually been infected are inaccurate, and also probably the deaths, who's having a COVID attributed death is also very difficult to measure. So one way around this has been to use the whole population as the denominator, which is starting to happen from, sort of hotspots like New York City. We can actually look at the mortality rates compared to, using the entire population as the denominator, not just infected cases. And I just thought this was really striking that, the total, considering the entire population of New York City, 0.23% of the population has died, and 1.66% of those 75 and over. So this, again, not just amongst the infected, but amongst the entire population. So I think at the very least, these numbers are putting to rest the idea or any hope that we had that there would be enough mild or asymptomatic cases out there that this virus was not as fatal as we feared. And, demographers are also very experienced at dealing with the challenge of measuring mortality, and have encouraged kind of the use of excess mortality as a better and more comparable way to look at deaths across countries, especially because countries are not measuring COVID deaths in the same way. So the FT and the Economist have taken to actually updating these excess death numbers, using just a comparison of all-cause mortality over these weeks compared to the similar weeks in the previous years. So kind of a simplified way of doing it. And you can see that there have been a lot of very notable excess deaths across different countries, and even more so within sort of these hotspots, sort of a 400% increase in New York City, 500 in Bergamo, just really astonishing numbers. I think that also lay to rest that this is, ever just going to be a bad flu season. And as more data arise, I think demographers can really help hone this type of analysis of excess mortality using a more model-based approach, and also, thinking about competing risks, who may have died soon anyway, will death from other causes go down in the future? Also thinking about important things like years of life lost. These are all things that are going to take time to understand, but demographers really have the tools to illuminate the full scope of the pandemic on morbidity and mortality. And just to show, looking at excess mortality across age, this is just from England and Wales, but we can see that this is really, again, concentrated at ages 45 and up, with no evidence of excess deaths for the under 45s. And just a note that measuring all-cause mortality and excess mortality is not, as easy in lower and middle income countries. So we do have to remember that. And some colleagues have called for some quick action to get mobile phone surveys in the field to try to capture more of this while it's unfolding. And so I'm going to leave it there. And hopefully we can talk more during the discussion about different aspects of demographic analysis going forward. I think as a discipline, we have a lot of great strengths. First off, sort of the interdisciplinary perspective, which I think I've never appreciated those skills, more than I have right now. Just the ability to read and synthesize evidence across lots of different perspectives is really important right now. And we have the ability to think across both micro and macro levels, which is very important, as well as, a strong history of examining social and race ethnic disparities in health and mortality to give context to the current situation. And this was just my example of how we should, be mindful of macro versus micro interpretations of what's causing differences across countries. And finally, I just wanted to give a really quick shout out to a science communication effort I'm really excited to be a part of right now that includes 10 academic women, many demographers, providing kind of interpretation of COVID science and practical advice for friends and family and a general audience. So please give us a follow if you're so inclined. Thank you.
Eileen, I think you're talking, but you're on mute.
Thank you, Jen. Following Jen on social media, both Nerdy Girls and on Twitter, will really keep you informed of what's going on with COVID, although it'll keep you very busy. I don't know how she does it all. But thank you very much, Jen, for actually showing us the most demographic thing ever. It was very good setup. Steve, can you now take over and share your screen? Steve Goodreau?
Sure. Can you all see the screen now?
Yes.
Okay. Thank you all very much for having me. And Jennifer, it was a perfect segue at the end into what I'm going to be talking about, which is a kind of public science project that I've been involved with, and then sort of some aspects of how that's moving forward into kind of in the other, taking your talk in the other direction, starting mostly with the public science, and then where is the demography heading next as we move forward to this epidemic. So the pieces that of demography that'll sort of work into what I'm going to be talking about mainly are maybe the fourth, fifth, and sixth most demography things ever after we do age, race, and sex, which are things like household structure, employment, and social networks. And in particular, the importance for public communication around what exactly is happening and what exactly should we all be doing in our daily lives for it. So, I had the experience like many demographers, but wearing an additional hat as a mathematical modeler, epidemic modeler, as this all started unfolding of, going from having to explain to people what I do and having them look at me funny, like it doesn't make any sense, and what exactly is an epidemic model, to suddenly seeing R not on the news and having my cousins, emailing me and asking what is, all of these things, and having everyone suddenly know about modeling. And so that was quite surprising and overwhelming to see that. And I think, and a lot of models, as you all know, started appearing in the news very quickly. And I think the models that we see, just like the epidemic itself, is going to have two phases, right? So the first models that all came out needed to really make decisions, very quickly, and needed to kind of take as big a picture as they could, and not necessarily get into all of the depths of household structure and all of that, as they sort of tried to get messages out to governments about what they should be doing. And in this case, I'm not just talking about sort of presenting results in terms of, how many cases would occur or how many deaths would occur broken out by age or race or sex, but in terms of the kind of the different underlying strategies that we might use to control it. So, so instead of, sort of the first order strategies being modeled and considered and that governments mostly adopted are all these very blunt instrument, everybody stay home who isn't an essential worker, sort of pure social distancing, that kind of thing. And I think, and that's what we needed, because that was what could get done that quickly in real time for so many different jurisdictions. And that's what the models focused on. I think as we move into the second phase, and I'll sort of end with this, the models, we're going to need a lot more strategies that are nuanced around these demographic variables, and that involve, stay-at-home orders that vary by age, or whether you're in contact with someone by age, like, someone who's elderly, like Jennifer talked about, and that's going to require understanding much more about household structure and age structure within households, and employment by age structure within households, and all that. But again, as this was all unfolding very quickly, that sort of was missing from this first wave of models and from sort of interventions as needed. So I found myself, you know, as this epidemic modeler, demographer here at the University of Washington, sort of as part of a small shop, working just with one other faculty member and our small group, trying to figure out what niche could we play in all of this as it's happening very quickly, knowing that we're a very small shop and our expertise is in HIV modeling, right? We're not respiratory modelers. We happen to be at the same university as one of the world's biggest modeling shops, IHME, and you know, and they were sort of out there, but we're you know, this other group, and our expertise is slightly different. So I was trying to figure out what role could we play, given our demography skills, our network skills, and our modeling skills. And so in the middle of all this, we started seeing a lot of talk about super spreaders and how super spreaders are a big part of the problem. Super spreaders matter, you know, people having these big parties, conventions, etc. And that's coming out in the news at the same time that also messages are coming out saying, stay home, don't see your friends, don't do anything, right? And there's a little bit of conflict there. I mean, they both messages matter, and both are important, but sort of like my colleague Martina Morris and I, who work here together, knew from our own experience in HIV how those two different messages simultaneously hitting people can get confusing and sort of be hard for people to sort of see their role and about how they should change their behavior and how their own little tiny network really matters in the midst of this, you know, these big super spreader events and all of that. I don't know if any of you are old enough to know what this figure represents. This is from the American Journal of Medicine, March 1984. If we were in person in an actual meeting, I would ask you who knows what it is. But this is a network graph of connections for this man over here, whose name is Gaetan Dugas, who is much more famously known as Patient Zero in the HIV world. That's him in the middle there, Zero. And he was one of the first people contacted and willing to sort of talk and engage in contact tracing with the HIV research community back in the very early 80s. And he had he was a flight attendant, and he had many sexual partners, as did many other people at the time, many other gay men especially. But he got sort of branded as Patient Zero. Huge public outcry about how, you know, that turned into these urban legends about people purposefully spreading HIV and so on. And he sort of got pilloried, and this became this, you know, idea of a small number of gay men purposefully spreading HIV to lots of people became an element of the mythos for HIV for a decade. And in many ways, I think hampered HIV prevention, because lots of other people heard, well, I only have 2 partners or so. I don't need to, I'm not that guy. So, you know, I can other him and I don't have to do so much of my part. Much of the story was since disproven from the genetic evidence. Yes, he had many partners, so did many others. He had no really special role to play. But we knew that story, and we knew how those, you know, super spreader narrative often sort of hampered behavior change for many other people, and knew just how much that fit into this sort of communication going around COVID prevention. And so that was the niche we wanted to fulfill, and particularly not in trying to build better models like that in the short term that got all that detail right and all the demographic complexity right, but that communicated a very simple message about how small numbers of connections for individuals or households can matter. So just to give you a sense of this is a tool that we've developed sort of long ago to do this in the HIV context. And given how little time I have to talk, I'll just tell you basically what's going on here is you've all seen the SI models and SIR models and heard all of these. This is HIV, so this is an SI model. And all it is taking basic numbers from data that we have for heterosexual populations they're sort of caricature numbers, but they're sort of the average of many populations. So the average person is in 0.8 relationships sexual relationships at a given time. The average relationship lasts 20 months. And in this first model, we just randomly distribute relationships. Anyone can, as a heterosexual, there's a purely heterosexual model with sort of heterosexual HIV transmission numbers behind the scenes. And if you purely randomly distribute relationships with those rules in mind, that the average relationship lasts 20 months and the average person is in 0.8, but those are the only rules, you get an HIV epidemic on the order of 25% prevalence, which is like among the biggest you would ever see in the entire world in some high prevalence HIV countries. If you change one rule, which is present in different societies to different degrees, which is that relationships aren't entirely random, but instead, if I'm already in one relationship, I'm not likely to form another one. That's the only rule, but still the same amount of sex, same number of sex partners, same amount of sex acts and everything, and you rerun it, think in your head what you think will go to. It was 25%. Now it goes to 0%. That one small change in relational structure, network structure, same amount of sex, same number of partners, is the difference between the largest HIV epidemic in the world and no HIV epidemic. All right, and so super spreader events may happen, but everyone's sort of local behaviors matter as well. So notice the only difference between those two scenarios had nothing to do with whether anyone had, was a super spreader and had lots of partners or not. It was just, did everyone, was everyone doing their little piece of the puzzle to not have two partners? So we knew, okay, that's the message we've worked on for 15 years, trying to get out to people in the HIV context. That's the role we're going to play for COVID. And we basically built the exact same thing, but did it in this context. Can I please just visit one friend? And you might already be thinking, wait, in the previous thing you were talking about people having two partners was sort of the glue that held the network together. And now you're saying, can I just visit one friend? What's the difference there? And the key demographic difference there is that for the HIV, we're talking about risk and sort of two partners per individual, people having two sex partners. Here, we change the unit of analysis that we want to present to people and make it the household. Okay, and so households most households, 75% of households in the US consist of more than one person, and the average household size in the US is about 2.5. So that's the one demographic fact we put in this very simple tool to tell people, okay, take the same principle. So we sort of walk folks through the basic situation. And back before there was COVID, we were all interacting with everyone all the time, and we have this kind of simple visual version aimed at kids or young people or actually anyone who's interested, or you can look at the numbers if you want and see that and go into much more detail about 6 degrees of separation and so on. If everyone could perfectly isolate, the network would look like this. But of course, we have essential workers. And so this is our sort of caricature of a network that involves, households that have an essential worker are in blue, and they have to have some sort of connections with people to keep society going. And so that tells you, okay, given the sort of basic way we modeled essential households, 26% of households would all be connected into this sort of large component of connections. And that's the trade-off we make in terms of there will be some deaths because of that. But, but we need those relationships to continue to occur because they're essential. And then if we assume people just all visit one friend, and again, there's more than one person per household, and each dot here represents a household. Blue dots are those with essential workers. Everyone just visits one friend. You go from having just a quarter of household connected to 90% of households connected. Or you can look at the visual and you get this sort of very strong visual image of how bad that is. Or if you just have one friend per household, you still get it. You still get some connection. So we go into, sort of given my time, I'll skip over that. But our hope there was by kind of going in the other direction and stripping out most of the complexity and just focusing on this one demographic reality of households and building that same sort of message that people would hear why their behavior matters in addition to the behavior of people attending parties and everything. It turned out to work, and we got lots of press, and the story got out there. My favorite was the New York Times article with lots of that reproduced some of the graphs and talked about them and managed to get all the details right. So I was very happy about that. Sorry. So what was interesting is, we stripped out the demographic complexity to focus on that key message. But what ended up happening then is I started getting lots of emails from people. Hey, I actually, I'm divorced and my son lives with my ex-wife and she has another husband, and and what do you think we should do? Meaning that, of course, the reality is that households are far more complex than the binary version we looked at. Age structures, et cetera, matters, and so on. So again, that was sort of phase one of this work, and I think both in terms of now improving on this, but getting, as we said, sort of ending where I started in terms of as we think moving forward, what do the messages need to be, or what do the strategies need to be about social distancing as we move into this long dance of keeping it going? We need lots of better strategies around household structure and the elderly within that household structure, and the age of those others who are in the household structure, who are in the same households, and what their employment type is, and so on. We need data from the census. We need our models to incorporate those, to be able to model different strategies much more carefully and in much more nuanced and much less of a blunt way, which basically is sort of coming full circle back to some of the stuff Jennifer talked about. So a lot of us have proposals in to try to do some of this work, and I think there's been all sorts of calls from NIH to do work like this, and so I think we'll be all hearing very soon sort of what we can move forward with on this. So we started doing some anyway, just knowing that even without the money there, but I think there's going to be, you'll be seeing lots and lots more of demographers and modelers playing roles in the sort of epidemic simulations around these more nuanced strategies in the coming year. So I will end it there. Thanks.
Thank you, Steve. It was a good addition of variables to what Jen had presented initially. And now we move to Marcia Castro, who will give us more geographic variability here. Can you share?
Yeah, Steve, you have to stop sharing yours.
Oh.
Oops. Okay, can you all see my screen?
Not now.
No?
I
Okay.
did before.
Just a second.
It was there.
Okay. How about now?
Good.
Okay, let me just remove this from here. Okay, so well, first of all, thanks again, PA, for organizing this. There's so much bad information circulating that the more we have of those events that really discuss science and facts, the better. So my focus here will be on Latin America, and more particularly Brazil. And this is sort of the story that is going on now. So if we look at the numbers every day, like I'm doing, what we see is a few countries in Latin America having a completely different trajectory from the US, the UK, and other countries in Europe that used to be the sort of the epicenter. So it was China, then Europe, then the US. And if you look at this, Brazil is the worst one in all of those curves, both in cases, this is cases and this is deaths. And just a few days ago, the US banned all flights coming from Brazil. This is a more detailed view just of the number of deaths due to COVID, and we see how Europe was the sort of epicenter of mortality, the US. And if we look at the number of deaths per day 2 days ago, then it's about above a third just in Latin America, most of them from Brazil. If we look at the deaths that happened yesterday, May 26, 26% of all the deaths due to COVID yesterday were coming from Brazil. So what I really want to do is to walk you through why you are seeing this. And here it's demography, but it's more. It's really a story about leadership or lack of thereof and inequality. And both of those variables affect demographic responses in a huge way. So I'm going to break this into three parts. I'm going to give you the context of where this is happening. I'm going to tell you the response and the consequences that it created. And the South America, and particularly Brazil, are now officially the epicenter, because once the WHO says it becomes official, we were saying that before WHO called it the epicenter. So what's the context? So if we, and again, I'm framing this around Brazil, but if you look at the country, there are serious issues around inequalities, and that is in any kind of social health and economic indicator, you would see this. If countries, I usually say that if countries had a last name, Brazil's last name would be inequality. So if you look at water, right? Water, having access to water allows you to exercise the very first recommendation to prevent against COVID, to wash your hands with soap for 20 seconds. So it's about 14% of the population in the country don't have access to water. And if you take one state in the Amazon region, it's 65% of the population, right? Then you have all the large number of people in informal labor market, living in crowded households with poor infrastructure. Those people cannot exercise social distancing. And I'll go back to that in a moment, connecting with what Steve just mentioned. If you look at other indicators like number of physicians and number of hospital beds per population, it's highly unequal across the country. Worst indicators by far in the Amazon region as well. We also have a polarized society, and I'll go back to that in a moment, but basically what that means is if you don't have a government that is really aligned around the same message, people are going to split. And that becomes a major barrier when you think about compliance to the actions being taken. Whenever you have challenges, you have opportunities. And the truth is, Brazil could have been the country giving the very best response to this pandemic, just like it did before when we had the HIV/AIDS, when Zika was introduced. And why is that? Well, Brazil has a universal health system that is envied by many different countries, and unfortunately, not really respected in the country. It's largely underfunded. And it has one of the largest community-based primary care programs in the world. And those two things should be directly connected to the response to COVID. And I'll go back to that in a moment. It has great scientists and scientific institutions producing science even without a lot of funding. And again, it has a history of responses. So the opportunity for Brazil was to really design a response to this pandemic that is adapted to all the inequalities the country has. Because if it's not adapted, if you just take the model of lockdown or social distance from Europe and drop in Brazil, it's not going to work. So you have to recognize those things. What happened? Something very different from this ideal scenario, right? So we have a president that does not believe in science, favors economy over health. We had 2 ministers of health in less than a month. One fired, the second one resigned. We have a current interim minister who is from the army and knows nothing about health. 2 days after the last one resigned, there was a protocol issued by the president for using hydroxychloroquine for COVID, despite the lack of evidence. The response is completely disorganized, and it really depends on mayors and governors to take the lead and provide some response in their cities. However, the message that comes from the top is a message that this virus is not a threat. It's just like a little flu. We need to open the economy. So you have this horrible conflicting messages coming from the federal, state, and municipal level that put a lot of pressure on the local leaders and really creates a scenario where you have cities responding the best they can. So it's almost a network of local governances, but without any direction coming from the top. Now, what are the consequences of this? The first one I want to talk about is how the disease was introduced, the virus was introduced and spread across the country. Now, I could use many different cities and the picture would be the same. This one here is Fortaleza. It's in the Northeast. It's the 5th largest city in Brazil. And here's the pattern of introduction. The wealthy people brought the virus because they go to Europe for vacations, whatever. In those areas here, they are the wealthiest areas in the city. So these are heat maps of the cases. This is the first 26 days after it was introduced, 11 days afterwards. What you start seeing is that the disease starts popping up in the periphery of the city, in the low-income areas. Why? Well, the rich people got sick, but they never gave up the people that work for them, cleaning their houses, driving their cars, and so on. So it was this pattern where the rich brought the virus, brought the disease, and then it progressively spread to the periphery, to the poor areas. This happened in Fortaleza, this happened in São Paulo, this happening in Rio de Janeiro, pretty much the same kind of introduction and spread of the disease. Now, what happens is once it gets into the periphery, it spreads really fast because you have very high population density. And what happened in this particular city is that the health system collapsed. So there was a shortage of hospital beds. And what you see in those maps are the deaths. So this one was cases. This one is death. So I showed you before, those were the wealthiest areas. Well, that's not where people are dying. So the high mortality is really in the periphery. And in this particular city, if you take the number of deaths, 90% of them happen among people who live in areas with low human development index. So what and again, this happened regardless of the city, the large city in Brazil that you take. And basically what we see is, and I'll mention this in a minute, when you look at the indicators of COVID, the inequalities of the country are basically portrayed in those indicators. And I'll show a few more in a minute. The second thing about consequences is this whole issue of social distancing. So I'll connect here with what Steve just said. The truth is some people in the country cannot practice social distancing. So they cannot self-quarantine. They live in a house that is very crowded. They need to go out and get some money with informal labor because they cannot work from home. And there is this pressure from business to reopen the city, supported by the president. So mayors and governors really have to stood up and go against the higher level of leadership. And what we see is that we have to rely on local initiatives. Some of them partnered with the government, some of them really driven by community initiatives. And it is those local initiatives that are providing food, providing care, being the doctors, being the nurses, being the people that come and care for you the best way you can. And this is the opposite. This picture here is a protest, not a protest, but a gathering on the street of people that support the president. So they're just making videos supporting the president. And each one of those agglomerations is an opportunity for the virus to spread. When we look at mobility, and this is data for Brazil, which is not the ideal because we can see lots of differences across cities, but people are driving more, and many cities now are talking about really reopening and going back into business, although there is no recommendation from the federal level on how to do this. Now, the third block of consequences deals with those inequalities. And Here, those two maps are from the city of São Paulo. So that's the largest city in Brazil, more than 12 million people living in here. In the map here on the left, each one of those orange dots is one person that receives the conditional cash transfer in the country. So basically, if you're poor, your income, the income of the household is below the poverty level, you are allowed to receive, you're entitled to receive the benefit. So you can see that this area right here is the wealthiest area in São Paulo. It's the nice neighborhoods and where the rich people live. Well, surprise, surprise, that's exactly the area where you have the lower mortality due to COVID. And this is mortality adjusted by age. So the higher mortality is really on the periphery, on the places where you have the slums and the high densely populated areas with low income people. Now, this is just mortality, but we see those inequalities in whatever indicator you take, whatever this indicator has bad quality because of the problems with the data, as Jan mentioned. So it doesn't matter if you look at incidence, mortality, you are going to see the inequalities. There's also inequalities happening because of the very, very high incidence in nursing homes. This is not just in Brazil. This happened in the US as well. In the fact that some of the kids that are out of the school, they cannot do remote schooling because one, the school was not ready, or those kids don't have laptops or even an internet connection. And as I mentioned before, some people can't work. So there is a fraction of the population that they're not just vulnerable, but they're also invisible. Some of those poor people are not even in registries of the government, so they're not even entitled to receive the social benefits. So I think my point in here is even before we try to make sense of some of those demographic indicators, we have to understand that there is an underlying inequality that was there even before the virus arrived that is going to make those things look much worse than they really are. Now, another thing that I want to mention is go back to this issue of the vulnerable. And here is results that just came out 2 days ago with the serology results or the serology test. So this is the percentage of people that tested positive for antibodies. So they were infected in several cities in Brazil, the cities that were sampled for this study. It's a large study they're going to do in all the country. So the cities inside a red box, they are all in the Amazon region, okay? So there are only 4 cities outside the Amazon region: Rio and São Paulo, Fortaleza, the one I mentioned, and another major capital in the Northeast. Now, if you look at the first one in Pará, in one state in the Amazon, it's almost 25% of the population was infected. Now, if you compare to São Paulo, it's only 3%. So that gives you an idea how different the transmission happened in those isolated poor areas compared to the major urban areas. And this is just a way to look at the capitals. Again, the capitals inside the red box are capitals in the Amazon region. And it's also important to look at what those numbers mean. So if you would take São Paulo, for example, the serology results showed that 3.1% of the population has antibodies. With a population of 12.2 million, that gives us an estimate of 380,000 infections of COVID just in São Paulo. Well, if you look at the numbers of the total number of cases of COVID in Brazil, May 15, 2 days ago, just this number for São Paulo was more than that. So yesterday, Brazil already had 391,000 cases. But basically, the message here is for each confirmed COVID case in Brazil, there are probably 7 more infections, but highly variable across the country. So basically, we have many different epidemics happening inside one single country, which is now sort of the epicenter. So to conclude my discussion, I think there are many things that demographers and epidemiologists, and I would claim that those two have to work together, will have to try to sort out, figure out, understand, explain in the next years, actually. And I think, first of all, one thing that I should say is I think Brazil still has time to change the course of the infection. They still have time to put together a very nice plan for reopening the cities after the social isolation. And I cannot imagine how Brazil is going to improve without bringing into the response the network of healthcare that they have. So the health system and the primary care. Here in Boston, they are hiring the COVID detectives to track all the people that may have contact with infected. Well, Brazil has those detectives. It's the community health agents, and they're not being used. So I am hopeful. I'm trying to be hopeful. I think it's the best way to put it. And I think there's still time and something needs to be done, because if we keep on the strand, I think we're going to move to the first place. And I would not like to see that happen. Now, in terms of the agenda that is ahead of all of us, I think there are many population groups that we still don't understand exactly what's happening with them in terms of COVID. And this includes pregnant women, includes children. We're just learning the things that are happening with children, and apparently they also happen in China, but we're just rescuing you this now. All the attention was in the elderly. And regarding the pregnant women, all the issues around reproductive health, and a lot of those services have been interrupted. Mental health, I think everybody's already talking about this, and the issues of violence. So domestic violence and violence against children is increasing, but it's not being reported as it should. We have a few online surveys going on, and we're just learning how bad the situation really is. This has long-term implications for everybody. And if you just name one, if you think about child development and the impact of this in human capital, there you go. You have impacts that can last generations. There's also the issue of what's going to be the impact both on morbidity and mortality on other conditions that may worsen because of the collapse of the health system, because of how it's stressed, cannot provide care, and because of the interruption of primary care. I think that there is a possibility that the inequalities in Brazil can even become bigger. Basically, the gap between the haves and the have-nots, that would be horrible. That would mean losing at least 3 decades of improvements in reducing health inequalities, inequalities in mortality that were achieved since 1988. So this would be the worst case scenario for Brazil and for the region as a whole. There is an unfolding discussion. If we do have a vaccine about a year from now, who's going to get it first? And this applies to the entire world. And there is a coalition now, an international coalition for vaccines. And unfortunately, Brazil for now is out of it. And last but not least, again, with a huge impact for demographers, is to think how the world is going to look like afterwards. And there is a good chance that there's going to be changes in how the urban looks like and how migration takes place. I think there's a chance that this whole issue of globalization may change a little bit. I think countries realize how bad it is to depend on others to ship masks to you, and they won't ship them to you. And last but not least, the whole idea of how humans interact with nature, I'm not sure if it's going to change, but I sure hope that at least some change on the positive side would take place. So happy to take any questions later, and thank you again.
Thank you very much, Marcia. I don't know how you're maintaining a positive attitude with news like this coming in every single day.
Yeah.
Obviously, a lot of what you did is just in the last 3 or 4 days. It's kind of mind-boggling. Now we turn to Andrew Noymer, who has been, I know, tracking very carefully parts of California. I know.
Thank you, Eileen, and thank you everyone for joining. Thank you to Eileen and Sara and Jennifer for organizing this. And I hope everyone watching at home is staying safe and keeping well. And thank you for supporting the Population Association of America. As I hope this webinar is demonstrating, we need population science more now than ever. I was asked to give some viewpoints on what population studies has to offer for our understanding of the pandemic. And a lot of the previous speakers covered aspects that I have been talking about a lot myself. So I'm glad that that they did so, and I really endorse all the fine work that's been presented so far. I'm going to be talking mostly about some heuristics, some really big picture things that we can keep in mind as we plan ahead for the pandemic. And just my standard disclaimer is a fast-moving situation, so people watching this archived on YouTube in the future, just keep in mind that this is the 27th of May, 2020. So I've been worried about this for a long time, and I think you can see more. Does the screen get cut off when I maximize? Like, anyway.
No, you're fine.
Okay. So I've been worried about this for a long time. I was, and I've been doing a lot of public outreach during this whole episode. And in January, at the end of January, after spending the better part of the month warning people about the terrible pandemic that was coming and being basically told this is just a seasonal flu, I tweeted out in exasperation that 2020 was going to be a wild ride and that people should make preparations for that. So I've been tracking this for quite some time. And one thing that demographers know well is the ancient Greek word demos, which is people, which is where the demography word gets its name. And it's the same demos in pandemic and epidemic. It's the same root. It's from the ancient Greek, and it means people. Epidemic literally means upon people. It's something that happens upon people. And so that's really why demographers have a lot to say about what's happening and why we should have a lot to say about what's happening, because we are the experts on populations. You know, there's a lot of talk about the virus and you know, vaccines and whatnot, but it's the people that matters the most. And I mean, some of Marcia's comments about the social effects beyond, you know, the SARS-CoV-2 epidemic, for example, what's happening to children who are in lockdown is such an important aspect of this, and some of the work on you know, epidemics as really drivers of inequality. I'm sorry to say, Marcia, that your comment about that really struck a chord. There's some excellent work, particularly by Sven-Erik Mameland of Oslo Metropolitan University, on how the 1918 pandemic was a big driver of health inequality a century ago. So, you know, I think we're going to see that here as well. On December 1st, that's a typo, 2019. On last December 1st, the whole world was immunonaive. So that would be the S for susceptible in Steve's mathematical model. So the whole world. So this is why I knew that this was not going to be like another flu. Because with flu, you know, the whole world is not immunonaive. There's people who have been vaccinated, over 1/3 of the US population every winter. There's people who had the flu, you know, 2 years ago from a substantially similar strain. And some work I've done with Ann Nguyen shows that, when the 2009 flu pandemic arrived, it was very mild, but younger people actually had much more enhanced mortality risks. And it's because younger people didn't grow up in the period 1919 to 1957 when H1N1 was the only circulating strain of influenza A. And so they were more immunonaive to the reemergence of this new strain of H1N1 in 2009. But nobody paid any attention because even though there was a risk multiplier for mortality for younger adults hardly ever die of flu. So you're multiplying a very, very low number by some factor, and you still wind up with a very, very low number of deaths. So the 2009 flu pandemic came and went. And I think that has a lot to do with the fact that we have been unprepared for this one, because there were all these bird flu scares in the early 2000s. And there was a lot of talk in the early 2000s about preparing for a pandemic. And then the SARS epidemic of 2003 it sort of enhanced that. And then the 2009 flu pandemic came, and it was kind of a nothing burger. And so people just sort of shrugged their shoulders. And I think a lot of the world government's preparations or lack thereof for this are directly related to having been lulled to sleep in 2009. But demography provides a valuable perspective precisely because the whole world was immunonaive on the 1st of December, 2019. Again, that's a typo. So we're literally talking about everyone on the planet is potentially a case of COVID-19, of SARS-CoV-2 infection. And so understanding populations is so important. It's no longer about, understanding, who's at risk in terms of who hasn't gotten their flu shot or who didn't have flu 2 years ago. It's more about everyone's at risk. So it's not about the epidemiology purely. It's about the demography. And I agree with Marcia that we have to collaborate with epidemiologists, and I sort of consider myself to wear both hats in any case. So here's what I'm calling my mini model. This is a heuristic. Sam Clark of Ohio State correctly dubbed this a heuristic. This is my heuristic for what's happening with American mortality. And you can do this for similar countries around the world, for those of us joining outside the United States. The death to case ratio as of last night in the US is 5.8%. That's sort of similar to the case fatality rates that Jen had in her slides. So if we assume that there's a 10-to-1 ratio of all infections to reported cases, that would give us an infection fatality rate of 1/10 of that number. So just over 1/2 of 1% for an infection fatality rate. So far, this heuristic is just based on the observed death to case ratio, which can fluctuate, but it's been actually remarkably stable of late. And this assumption, which I haven't changed since I've begun doing this exercise, that we're dealing with a 10-to-1 ratio of cases discerned to total infections. And the next ingredient of this heuristic of the mini model, what Ron Lee called comparative statics, is that 70% of the population is going to be the final size. So, nobody knows what the final size will be. I mean, this is an estimate. If you assume an R naught of around 3 1/3, and you assume sort of the standard model, then the herd immunity threshold would be 70%. But of course, the standard models tend to overshoot herd immunity thresholds when estimating final size. So, it's really anybody's guess. I mean, you could say, well, 3.33 is too high, so 70% is therefore too high for the final size. But you could also say, well, but we tend to overshoot. anyway. And then some people say that we'll undershoot because of, for example, studies of measles in the Faroe Islands in the 19th century, they tended to undershoot their herd immunity thresholds. So it's really anybody's guess what the final size will be, but I think it will be north of 50%. And just as this overall model is a heuristic, so 70% is kind of a heuristic. So let's just say 70% of the US population will get SARS-CoV-2 infection, and there's about 328 million Americans. And so when you multiply 0.7 by 328 million, and then multiply that by 0.0058, you'll get that 1.33 million people will die in the United States by the time this is over. And I write there, not a forecast, just a gut check. And that's, again, emphasizing that this is just a heuristic. You know, I update this every day. So, you know, this number can change. It's not set in stone. Marcia, you said something about how there's still time. I mean, whether or not we reach 1.33 million deaths depends a lot on what we do in the United States between now and whenever. So I think there's still time everywhere to make a lot of changes. We just crossed 100,000 deaths in the United States on Monday, and at least in the tallies. And so it's too early to say that for sure that we'll have 1.33 million deaths, but as a persistence forecast and making some, you know, general assumptions, we can expect 1.33 million deaths by the time this is over. And let me show you what the data look like. The mini model prediction is up here, and the actual number of deaths is down here. And you know, the number of deaths has been rising, but it's plateauing off, which is good news. I am expecting a fall wave, but that's a story for another day. And the mini model number of deaths has actually declined. It's hard to see on this scale, but the mini model is not monotonically increasing. It changes when the data change. And just as the mini model is a heuristic, I have another heuristic for when we can say the pandemic will be over is when these two lines cross. When the actual number of deaths equals what this what the most up-to-date version of this little model predict, that's when the pandemic phase of this will be over. So the mini model doesn't have an express time envelope. I'm not saying that there'll be 1.3 million deaths in calendar year 2020. It could take 4 years to achieve 1.3 million deaths, but I'm saying it's very unlikely, absent a vaccine landing like a ton of bricks and ending this all, that we will avoid 1.3 million deaths in the U.S. And for those of you who aren't, you know, U.S. mortality people, there's about 3 million deaths a year on business as usual. So that first stage will be when those two lines on my mini model cross. And that's anywhere from 12 to 48 months. That's where we are now. That's the pandemic. After that, I expect COVID-19 to be a seasonal phenomenon. So we'll have winter and flu winter flu and COVID co-circulation. And then eventually I expect genetic drift to make this a much milder syndrome. And we have coronaviruses that cause the common cold now. And my prediction would be that eventually, 25 years from now, that SARS-CoV-2, as it has in its evolved form, will be like another common cold. I studied the 1918 flu pandemic. That virus didn't really go away, it just drifted. So from 1919 to 1957, the only strain of influenza A in circulation was H1N1 that had emerged in 1918. It didn't disappear, it just drifted away to lower virulence. And I honestly expect something similar with SARS-CoV-2. And I don't want to speak a lot about mortality models, but I have a framework up on Twitter for understanding COVID mortality. I put this up there just over a month ago. Basically, the excess mortality models that were in some of Jen's slides are going to have to be how we understand this. The dashboards that count COVID deaths are really looking for COVID deaths that are known to be COVID deaths. And there's going to be a lot of pneumonia mortality. There's going to be a lot of cardiovascular mortality by the time this is all done. And we're going to have to look at, excess mortality models. And, we will never know exactly how many people die of COVID-19 because, in the flu world, there are different models for calculating what the baseline is. And the excess is whatever's above the baseline. And people argue all the time about, the correct way to do to estimate the baseline. And so people will argue about how to estimate the COVID baseline. And so, I mean, we don't know now exactly how many people have died from COVID, and we won't ever really know because people will argue about, what was a competing risk and what was a real COVID death. And there will be competing estimates, and I mean, let's just put it that way. This is not only in Brazil, but in the United States and the United Kingdom, and I believe in other countries as well. The COVID response is becoming politicized, and so the excess mortality estimates will become politicized as well. I predict, and I just think the solution to that is transparency, to make our data and methods available, and to just say, here's the assumptions I made, here's why I made the assumptions, here's the code, here's the input data, and that way we can have a scientific debate about how to count COVID deaths that I don't want to say won't be politicized, but I think transparency is a really important value, and one that the Population Association of America has often embraced. So I don't know where I am on time, but I think I'll wrap it up there. The other speakers did such a great job of talking about the specifics. I wanted to give a population perspective sort of from 30,000 feet, but as you see here, we have about an order of magnitude to go in mortality before this is done. And again, I don't mean by the end of the calendar year, but this is, we have a long way to trudge through the woods before this thing is over. So stay tuned, and I hope to see everyone in St. Louis, although I am somewhat apprehensive about that. But I'll end it there. Thank you.
Thank you, Andrew. That was quite a sobering end. Now, I don't have any questions in my chat box, but Sara said she had a couple of questions. Sara, do you want to introduce those? And anybody else who wants to ask a question, put it in the chat box.
Thank you. Thanks, Eileen. Thank you, everybody. That was a fantastic array of talks and very encouraging. And I do hope that our audience will join us in asking some questions. So first of all, I have a question from Christine Percheski, who wants to know from Marcia, is it known how indigenous people in Brazil are faring? Is the situation similar to that for the Navajo Nation in the US?
So thanks for the question, Christine. They're not doing well. So the Amazon region in Brazil, where the large majority of the indigenous population is located, was badly hit by the pandemic. And as you saw from the numbers that I showed on prevalence of people with antibodies, it's extremely high. So in those areas, all that needed was people to take a boat and go to a village, go to an indigenous reserve, and everybody would get infected. So both the prevalence and mortality among indigenous populations for COVID is disproportionately high. And that's where they are in the Amazon region. So we see the inequalities right there as well.
Yeah, so it sounds like it's similar to the
Yeah.
to the Navajo. Eileen, do you have I have another one, but okay.
I do not.
I have Krista Pereira, I think is perhaps asking a question. Maybe this is directed towards Jen or towards, for Jen. What efforts have been undertaken to collect data on sexual orientation and gender identity in relation to COVID-19 testing, diagnosis, and treatment? And then I have a few coming in. So Jen, go for it. Oh, sorry, Jen, are you not? Yeah. Oh, Jen.
There I am. Yeah, great question. I would say, to my knowledge, we're nowhere near having any data at that level of detail. As I said, I've sort of been tracking the national or subnational level data, and it's often, just a struggle to get it disaggregated by age groups or biological sex. So I know that a lot of the cohort studies here in the UK have started fielding extra COVID surveys, and there's now sort of an longitudinal population-based survey with 100,000 people being put into the field that hopefully will be able to better tap into those real individual characteristics. But I mean, I think it highlights in general that we're really struggling with data right now. And I think, just to point out Andrew's point about sort of open science, I think it's been great to see people's intentions to share data and code. So I think that's been a great movement. There's sort of, I've seen very little sort of territorialism. People really want to share data when it's available. And I know that Max Planck is trying to aggregate and harmonize just age and sex disaggregated data across many countries, and other groups are making similar efforts. So I think there has been a great spirit towards open science that I hope kind of continues even after this crisis. But we need to kind of think about, data collection, and in our next PAA webinar, in fact, we're going to talk about data collection and COVID. So in order to get at these more nuanced questions that you were asking about.
Thanks,
Thank
Jen.
you. I have a question from Dana Glye. I think maybe this goes to Andrew, but maybe somebody else wants to tackle it too. She says many researchers suggest that the true number of COVID-19 related deaths are probably about twice as high as the number coded to COVID-19. Does anyone have a sense of how many of those unreported deaths might be directly related to COVID, just not coded as such, versus deaths that might be an indirect result of COVID?
I'll take a stab at that. I mean, I think that's probably about right. There's a lot of data coming in now on excess mortality, and NCHS is making some data available in more or less real time, which is incredible, because typically they take about 13 months after the end of the year to make the data available. So real hats off to Bob Anderson and his group at NCHS. There was a news story based on data from New Jersey that all-cause mortality for the entire state of New Jersey for the entire month of April. So it's what was double in 2020 what it was for 2019. So that is significant. I mean, New Jersey is a relatively large state, and a month is a relatively large time bin, and for them to double mortality on a year-to-year basis is really spectacular. And I believe around 40 to 45% of what we would consider excess in a crude model in that situation was accounted for by known COVID deaths, and the other 60 to 55% was just whatever. And so so I think double is about right. Now, we can get lost in the weeds about, well, how many of those were COVID deaths, and how many of those were people, too afraid to go to the hospital or something, and then therefore died of, of whatever. And I mean, my Twitter thread on the 4 types of COVID mortality tries to get at this, but you have to ask yourself, are we talking about people who died of SARS-CoV-2 infection, or are we trying to answer what would the universe have looked like if COVID had never emerged? And so, I mean, if COVID had never emerged, I don't, then we can basically chalk most, if not all, of that New Jersey excess mortality to COVID. I mean, it doesn't matter in some sense whether or not some person died of diabetic complications, but it was the result of being too afraid to go to the hospital. But it is a good question to ask, though. Well, okay, but how many of them were actual COVID infections? And we're going to have to sort that out with the excess mortality models. We're going to be poring over these data and looking also very closely at what's heart disease deaths. Are they going up? Are they going down? Some causes of death may go down because of competing risks. And believe me, there'll be plenty of more mortality in calendar year 2020 than we were expecting. So it's not going to net out to zero. Some people are saying that. I keep hearing that, in fact, from non-experts, that it's going to net out to zero. That it's all just a bunch of latent hypertension, and it's just it doesn't work that way. But it's an excellent question. Thank you, Dana, and I hope you're staying.
Can I just jump in there? Just to add that I do hope as the data come out over the next few months, we might be able to tease that out about the direct and indirect a little more. And one thing is, since there's geographic variation and where these COVID hotspots were, but everyone was sort of under lockdown and afraid maybe to go to the hospital, we might be able to look at changes in areas that didn't have as intensive actual COVID infections and look at how mortality from other causes changed across geography. So something to look for in the future.
Yeah, just one thing. I think when we get to that data, we have to bring an additional piece of information, which is the pressure on the health system. So, for example, in Brazil, many cities, hospital beds were over, so the hospitals were completely crazy. We need to also have those events by time to then be able to look at excess mortality. So it's going to be causes of death, daily deaths, and what happened with the health system in those days. Otherwise, we're not going to be able to understand what happened.
So I have a bunch of questions, and I thought maybe I'll run through them and direct them, do traffic control. And if the speakers, if you all could just take notes on what the question was and who is asking it, then you could reference it as we walk through it. So Ben Seligman has a question. I think this would be directed towards both Jen and Andrew, maybe Steve. And there are several questions around numbers and knowing whether or not we're actually getting at numbers. So Ben says, I wanted to ask about adjusting the numerator. Testing practices differ widely across institutions in the US, never mind across countries. Excess mortality will likely include a lot. Is there any sense of how to get the numerator right? So a little more clarification on the numerator on this question of excess mortality. Gretchen Donahauer asks, how do we know that states are, maybe massaging data? How do we know how good the data are? I think Andrew might have some insight on that. Biadad Urdinola asks, could you please ask Andrew how could we correct for under registration? So we've talked a little bit about that. And then Mieka Tomir is, have we seen evidence of any increases yet in deaths due to suicide or family violence? Are there other causes of deaths that may be very indirectly related? Rebecca Clark from NIH wants to know, one thing I've been noticing is the separation between those doing modeling efforts that are guiding policy and those who are publishing, applying for funding have been at times non-overlapping groups. Are there ways we can bring those efforts together? She asks selfishly. Oh, I'm sorry, this is a question from Jimmy Adams. And then finally, a question for Andrew, given your speculation on future genetic drift of SARS-CoV-2, making it less of a threat, what are your corresponding thoughts about vaccine development? A question from Malia Jones. How can we get data on age, sex structure? if there isn't any data around, where can we find that? I have one more, which is, could Steve talk a little bit about the parallelism he expects between HIV and COVID-19?
All right, so since you did that, Sara, I'm going to add in too, and then we'll say the questions are on the table and we can figure out how everybody gets one chance to answer everything. Because PAA also asked Marcia, what kind of strategies could you target for those suffering the burden of inequality in Brazil, which seems directly related to what you talked about. And I would like to get Steve to comment on what he thinks about the overwhelming concentration of cases in the United States in nursing homes, and given the living arrangements, communal living arrangements, and the cases that arise out of those situations. So I think we have all our questions on the table, and each panelist gets to address some of them, and then we'll be done. And as usual, we will have run over a little bit longer than a normal PAA session. So Jen, do you want to start? Let's go the order that we did in the presentations, and each person gets to address the questions addressed to them.
Sure, I'll try to touch on them, but Andrew might have, some more details on the US data. You know, I feel like I've seen a news story about some increases in suicide recently, but our weekly death data, for which we're starting to estimate, you know, excess mortality, first of all, is lagged a couple weeks. We usually don't get all-cause mortality that quickly because we don't usually need it, you know, in real time. During a normal year. And that's, to my knowledge, not coming out with cause of death linked to it. So I think it's going to take a little more time to look at increases. But I have seen some news articles referencing increases in suicide and an uptick when it had been declining in opioid deaths again in the US. So I agree that's very concerning, and things that we'll have to look at the consequences of lockdown and social isolation. And thinking about modelers and I guess other people working together, I might leave that for Steve, since he's at the institution with the IHME folks that were getting a lot of press about their model. But I agree, it did seem that you know, certain things were getting put into the news and having a lot of reliance. And here in the UK, of course, the imperial model sort of changed policy overnight from a herd immunity policy that was being talked about to immediately changing course when the model was estimating hundreds of thousands of deaths. So I think it's become clear how important these models can be for policy, and how they were kind of on the shelf and dusted off after decades of being used for flu projections in some cases. So I think going forward, we should find a way to all be kind of more involved in feeding in, you know, realistic assumptions into these models. And as far as age, sex, structured data, I think there's a lot of good country level and even local area level data. I know I have a good link, which I'll try to tweet out since I don't have it at my fingertips, but we do have a lot of good data on that. But what we're not getting kind of in return is the death data, you know, and it's also just not harmonized very well. So New York City, for example, has been really good at putting out their deaths data, but they have sort of very wide age ranges, sort of 15 to 40, you know, 45, and things that don't really help us compare to other countries or contexts in a direct way. So, you know, getting it out as granular as possible from, you know, for whoever at the local level has control over that data would just be really helpful for the research going forward. And I think, I'll pass it on to Steve, maybe.
Steve. Thanks.
Okay, great. I think there are lots of questions, so I'll do my best. First thing I want to say isn't a question. It's actually sort of just connecting back to Marcia's talk, because of course hers was so much about the inequalities and all the people who can't follow social distancing for many rules. And I just wanted to say, because that is sort of in implicit in the audience that I was imagining in the tool that we created, of course, was this sort of, set of, people in the US who are in situations where they can make, where they can, it was about the dispensable relationships, right? Can I just see one friend? And there's a lot of, text behind the scenes explaining about all the other kind of people who don't have the privilege to make those choices and why it's extra special that those who do follow them because so many other people are not in that position. And so I just wanted to thank you for that, Marcia, and connect that. Lots of things to say. On the nursing homes and side of things, I think we've seen discussions of this in the news already. About in terms of staff at nursing homes and how underpaid they are traditionally, and therefore how many of them work in multiple settings and multiple jobs. I had already seen, before any of this came along, in December I was at the epidemics conference, and there was this amazing talk by this researcher Vittoria Kulitsa, in intern in Paris, basically modeling nursing home staff and this situation about them sort of working multiple shifts in multiple places. And she had done this data-driven model showing just these simple changes in staffing rules could cut MRSA cases by about a third, right? This is long before any of this came out and before COVID was happening. And so that, I just keep coming back to that in my head. And I think the same work she's doing there, that same sort of insight about nursing staffing, that has to be sort of the key component to that. Of course, that requires, paying people a living wage, which gets us into political territory. But on the science side, I think there are some clear strategies there that we kind of already know what they are, but the modeling can help support that. In terms of similarities with HIV, I think there are, for the long term, there's of course many differences. HIV is a very slow acting, lifelong infection with no cure, spread sexually, so on a very different substrate. So I think on first pass, you would think in the long term, there's going to be almost nothing similar. If when you learn about epidemic models and how the difference between things with cure and things without, and the difference between things that are short and things that are long, epidemic infections that are long-lived, the mathematical dynamics of them are almost entirely different. But one thing I do see as very similar is the issue of behavior change fatigue, or prevention fatigue. And I've already found myself saying to people multiple times, I've been hearing for the last 30 years of my life, oh, why can't gay men just, why is there still so much HIV? What you have to do? You just have to wear a condom and you're done, or why is it still so high in this population? And now I can say, you know what? People had to wear masks for every time they, for their one trip a week to the supermarket for all of 2 months, and they couldn't handle it. Now, you know what I mean? And they were freaking out, and this is an infringement, and I can't, I'm just tired of it, and so on. That's why, and now you understand why telling people to use condoms every time they have sex for 30 years gets is a little hard to follow, right? And so I think that, depending on what happens with the virus, and there's a possibility it could mutate to be something less virulent, which we have reasons to believe happened, and so on. But this same sort of level of fatigue and then the next generation who doesn't remember how bad it was, and then and up and down, that feedback, I think, is very possible, and that's very similar. I'll leave the numerators questions and the data questions to others. I will say that, the sort of working modeling, I know a bunch of people who are kind of collaborating with, states and modelers. I know Jimmy Adams on here at UC Denver is working with the IHME folks and with the state health department. We have folks in our group here working with our state health department. So I think, I don't know what, in terms of the federal government, sort of all that's happening, but at the state level, I think those collaborations are growing. I think the question about who's applying for funding, I think, folks like IHME don't necessarily need to apply for funding because they're working so closely with Gates and are able to, it's in part the groups that have this sort of dedicated funding that were the ones who were able to pivot so quickly at such a high level. But I think as we move into the next phases, we'll see more of that. And then actually, I'm going to add a question onto Marcia's list, which is the comparison of Brazil and India. So as this was all going down, my husband was trapped in India with his mom, and I was sort of watching it all unfold. And India is similar to Brazil in so many ways, and the inequality and the staff and the climate and so on. They of course instituted this interstate movement law much more quickly, and have had an epidemic, but a much smaller epidemic. I'm just wondering if you have any thoughts of those two, the comparison between those two, or if they're just too different. You haven't had a chance to process that. Thanks.
Okay, so my turn. So let me just say very briefly one thing about the models. I think that some of us are engaged with other groups, large groups. This work cannot be an individual work, it has to be a collaboration. So some of us are involved in collaborations that includes models. And I think besides doing the work, I think it's our duty to clearly communicate what models can and cannot do, because models are spreading faster than the virus. It's unbelievable the amount of models out there. The vast majority, they're useless, right? So just like we have opportunistic infections, we have opportunistic modelers that create a lot of noise, doesn't help at all. And I mean, don't get me started with that. So I think they're useful, but just as we do them, we engage with people doing models, we have to make it very clear what they're capable to do and not to. So I'm done with models. So Piedad, so I think what is absolutely crucial is, again, in the case of Brazil, because we have those community health workers, if they get proper training, if they get the protective equipment, they have registers. They know where the elderly are. They know where people with comorbidities are. They know where the households that lack water and infrastructure are. So involving this very large network of agents, community health agents in the response, one, allows you to do contact tracing. Two, allows you to actively find people that cannot do self-quarantine, but probably were exposed. And honestly, you can make deals with hotels that are empty and put those people in there. New York did that. But when you reach a certain level of the pandemic and you haven't done anything like that, you're always, now we start working on what we call in public health, the fire brigade model. You're just trying to manage fires, but not preventing the house from being fired. So to me, addressing the local inequalities is through engaging community health agents that live in the community, know exactly where are those people that need care. And from the government side is to provide social benefits. The US did that, Brazil did that, kind of late, but here's the catch. If you inject money into social programs to help those people so they can stay home instead of trying to make some money because they depend on informal labor, you have to do this, but then you need the actions to stop the spread to work alongside. Otherwise, they're going to keep dragging, and then the government runs out of money. You're going to have a debt that is as big as the GDP. So if you don't do both of them alongside, we're going to hit a wall that then we're really in trouble. You don't have any more money and people are still dying. India, that's a very interesting story. So there are places in India now that hunger is increasing because people were, put into isolation and people can't provide. I think we are still going to hear a lot more about India. I don't think we are done. I'm not quite sure if India is going to be, it's going to keep the same way it is because of the local conditions. So I don't know. I think we're going to be hearing more from India in the near future. I don't think this is going to be such a nice story as it is so far. I may be wrong. Hopefully I'm wrong. And I'm going to do just like Steve. I'll drop one quick question for Andrew. So your number on the deaths, right? You mentioned, unless I got something wrong, you mentioned case fatality rate, and then you assume 70% will get infected, and you calculate the deaths. But when you do this, you're assuming that asymptomatics are also going to die, unless you're talking about an infection fatality rate. So I was a bit confused of your 1.3 million deaths if you're taking all 70% infected and you apply a fatality rate based on cases or based on infections.
Okay, is it me?
Yeah, it's
Yes.
your turn.
All right. So let me just answer your last question, Marcia, first before the audience questions, because it's an easy question to answer. That the death to case ratio is just under 6%. I'm assuming an infection fatality rate of 0.6%. So I'm applying the infection fatality rate to the whole population, not the case fatality rate.
Okay. All right.
And
Thank you.
You still get 1.3 million. It's a big country. So now to the audience questions. There's so many of them. What is up, Gretchen, Piedad, Rebecca, Jimmy, Malia? Good to hear from you all. Sorry we can't see each other in the conference hall, but at least the chair of the next session isn't barging in and making sideways looks at us, as usually happens. So let me try to answer as many of the questions as I can. Gretchen, your question about data massaging is an interesting one. And there was a resignation of a state official in Florida over alleged meddling in that. And this is why I think all-cause mortality is so important, because the Social Security Administration in the United States and similar agencies in other countries have a lot of skin in the game of making sure the deaths are recorded, because they're sending out checks to retirees. And so, I think we'll be able to at least get a sense of what's happening with all-cause mortality without political pressure of, I'll call this a pneumonia death, not a COVID death. So even if there is some sort of incentive for subterfuge in the statistics, I think at least all-cause mortality will be counted correctly, and we can do our best to understand those data. As to the point that was made by questioners and by Marcia about models, I would just remind you that some of the early models predicted 60,000 fatalities in the United States. We're now at 100,000. And when I started putting up the mini model, the first numbers were around 500,000. And people assured me that that was impossible. That 60,000 was what the models were saying. Well, we're at 100,000 now. And I certainly don't think 500,000 is impossible in any way, shape, or form. I do expect a fall wave. And we see this with a lot of respiratory diseases, that transmission is just enhanced by the autumn in the temperate zones. And I've been telling my Twitter followers to steel themselves for the fall wave. And I think this speaks to some of Steve's comments about fatigue. Some interesting questions about suicide. The NCHS real-time mortality data does not include suicides. It includes all causes, pneumonia, and, if I'm not mistaken, cardiovascular, but the suicide is not broken out. Suicide is really tricky. There are economic aspects of what's happening. There's a big recession, and there's also the epidemic and its lockdown. And those two are, of course, intimately related, but recessions don't necessarily bring more suicide, conversely to what people might suppose. And my colleague at UC Irvine, Tim Bruckner, wrote a paper on the Great Recession in the United States, in which he found that he didn't see an unexpected number of suicides during that period. Suicide is a social phenomenon, and it has to be understood socially. So there's actually a lot of solidarity happening with the lockdown, even though we're isolated. So I think it just remains to be seen whether suicides will increase, and I'm not personally expecting a big spike in suicides, even though we're socially isolated. It's not purely speaking social isolation that causes suicide. Suicide is a complex phenomenon. On the other hand, I wouldn't go so far as to say suicide, that I would rule it out entirely either. And those of us in the United States know that in March, there were a record number of firearm sales. And those often result in suicides later on, sadly. So that's something that might argue for the other direction. Someone asked about a vaccine. I am not, personally optimistic that we'll have a vaccine soon, but the local paper called me Professor Dark Cloud, so you can sort of weigh that with the source. I don't wake up every morning and pore over the news feed to see what's happening on the vaccine front. I think when the vaccine comes, we'll all know about it, and we won't need to going over the news will not make it come quicker. The people who work with the wet lab stuff, are working around the clock to find a vaccine. And, I think the bigger concern will be who gets it, as someone, I believe Marcia may have mentioned in their talk, because there won't be 4 billion, doses overnight, and or 8 or 7 billion even. So, who gets the vaccine is going to be an interesting question. Rebecca, I've been doing mostly public outreach, and I feel that's like an important role that that we can play right now. I've been doing some of what you might call, COVID research, but I've been mostly trying to communicate the dimensions of the crisis to the public, who all of a sudden are really interested in mortality and are desperate to talk to someone who understands mortality. And so I don't know about the two groups you're referring to and the lack of overlap, but I feel like there's a role that we can play in this crisis to helping the public understand what's going on, because they're desperate for that. And I think producing the millionth model or something is not going to be as helpful as just me helping the public understand. Here's how mortality is counted. Here's what is the difference between an underlying cause and approximate cause, and things like that. That is sort of my stock in trade during calmer times. I guess that's
Good.
all I have. The age and sex, I don't have information on that. I think there are some data repositories out there. The NCHS real-time data is not disaggregated, is not broken down by age and sex like demographers are. And the data in due course will all become available. But to give you guys a sense, that the 2018 final mortality microdata file was released in January of this year. So about 13 months after the last death in that data file occurred, the final data was released. So, and then of course about 25 months after the first death occurred, because it's a calendar year file. So, so under normal circumstances, I would expect the 2020 calendar year data to be released in January of 2022. I'm sure that Bob and his team at NCHS are working feverishly to expedite that this year, but we don't even have the 2019 final microdata file yet. So the most detailed data will have to wait, and the data that are available in real time have a disclaimer that they're provisional.
All right, thank you, Andrew. Thank you and thanks this entire panel for really a very good session. It all went together very well, and people really were informative on these different aspects. So this is the first of a series, and The next talk that we're going to have is going to be on June 23rd. And that topic is going to be the inclusion of COVID in large US national surveys. And that session is being organized by Pam Hurd. And it's going to include David Weir from the HRS, David Johnson from the PSID, Vicki Friedman from NHATS, Carolyn Halpern from Ad Health, and Ari Kaptein from Understanding America. So that will be a very different type session about how data are and will be collected relevant to COVID in large US surveys. And then we're expecting the third session, which doesn't have a date yet, but we're expecting it to be in the first half of July, to have an international focus. And that session is being organized by Giovanna Merli. So that's the plan. More will come. Sarah, do you want to end?
No, thank you
comment?
thank you for everyone. Thanks for helping us work through this technology, to our technology team, and thank you to PAA for live streaming.
Thank you very much to both, to you and your group, because it was somewhat difficult to put things together for the first time here, but it gets easier every time we do something new. And this is how virtual PAA will go on for at least probably the coming year. Sara and I are in business until January, and we'll keep it going that long in order to make up for the 166 sessions that didn't happen in Washington this spring. So anybody that has great ideas or wants to host or organize a session, write to either of us, and Jen is sort of chairing this COVID section of things. So give us your ideas, and we're willing to try to run with them. So thank you very much. And we've gone over by a good half hour. We'll see you all next time. Bye-bye.
Thank you.
Thank you.
Bye.